As you all know, angle closure glaucoma is a fairly common problem we encounter in this part of the world. And so this situation is not really a rare one. Now, in order to understand what to do if a laser iridotomy does not open the angle up in a patient that we've diagnosed with angle closure glaucoma, we need to understand clearly what the pathophysiology of primary angle closure glaucoma is. So really quickly, I'd like to review this. The underlying problem is one of pupillary block. In eyes that have a crowded anterior segment, the aqueous does not have an adequate pathway between the lens and the iris, and this leads to a pressure gradient with higher pressure behind the iris, forward bowing of the iris, and occlusion of the trabecular meshwork. Obviously, in acute angle closure, total pupillary block occurs, but this is not, in patients with relative pupillary block, we still see this forward bowing of the iris. Now, it's also important to recall that iridotrabecular apposition from angle closure or any other reason can lead to peripheral anterior synechia with adhesions rather than simply apposition between the iris and the trabecular meshwork when inflammation or long duration are present. And this is something we're also keeping in mind as we're examining these patients. Now, because of this mechanism of pupil block, the treatment is to eliminate the pupil block, to create a channel for the fluid to pass from the posterior to the anterior surface of the iris and eliminate the pressure gradient. And when we do that, the flow of the aqueous is reestablished and the iris flattens out, and ideally, if there's only been apposition and not synechial angle closure, the angle will open and everything will be happy. And this is what we're looking for after we do a laser iridotomy. Now, we want to get an idea of whether this mechanism is happening before we perform the iridotomy, of course, so we examine our patients beforehand and base the decision on going ahead based on gonioscopic examination, where we judge the angle width in its natural configuration. We try to get an idea of whether there are peripheral anterior synechia present and how much of the angle are closed, and this has to be evaluated by dynamic gonioscopy. So real quick here, I'd like to have you look at this video, which was given to me by Max Forbes, a former colleague at Columbia University. The idea of dynamic gonioscopy is, as you'll see here, pressing forward with this gonioprism that's smaller than the corneal diameter. And by pressing forward, here's the natural iris configuration with this convex iris, and when pressing, it flattens it out, and we can now see the trabecular meshwork. So mechanically opening the angle by pressure forward can help us to see whether or not there's synechial angle closure, and we want to do this before we've examined the patient. Before we do laser iridotomy, to get an idea in advance of what might happen. So here you can, an illustration of the natural and then the open angle configuration in a patient with dynamic gonioscopy when there's only apposition and no peripheral anterior synechia, in contrast to a patient where when you press forward, if there are adhesions, then we get gaps in the open angle that are closed by these synechia. We want to look at that beforehand. Then, what do we do after the iridotomy? Well, of course, we're going to repeat gonioscopy, but we also want to make sure our laser iridotomy is patent. And so we look at it directly with a slit lamp, and we can also retro-illuminate, as in this photo, to see whether or not we think that iridotomy is open. It doesn't need to be big. Even a few micron diameter opening will give the equilibrium between between pressure in front of and behind the iris, but it needs to be patent. So we repeat gonioscopy, and we want to judge the angle width, whether or not it's greater in its natural configuration to that which we saw before the iridotomy, and we want to reassess for peripheral anterior synechia. The intraocular pressure may or may not improve according to how much of the angle opens up and the amount of peripheral anterior synechia. I've got this delay with the video. So here is an anterior segment OCT image of a normal anterior chamber angle that's open. And here's a patient with a narrow angle before laser iridotomy. You see when the pupil's enlarged in the dark, the angle's closed, and it might open a little slit there with the pupil constricted. Here, the angle after iridotomy is open more in its natural state, and again, with pupil constriction in the light, it opens even further. We want to be looking for this in our examination of the patient. On gonioscopy, and also anterior segment OCT can help us to compare the angle in its natural configuration before and after iridotomy. Now, what do we do if we do all of this and the angle seems not to have opened? That's the topic under discussion. We now have the groundwork, or the foundation upon which to make some adequate judgments about what to do here. The first thing we need to consider is that the iridotomy is not patent. Here's an anterior segment OCT that shows a small membrane that's still occluding the iridotomy, and you can get iris transillumination when there's a thin membrane still present. So if the angle width did not improve, take a look at the iridotomy carefully and consider doing a little touch-up iridotomy to open the angle further. Now we need to also do our repeat gonioscopy and see, is there peripheral anterior synechia present? So in this example, you can imagine that a laser iridotomy was done in the angle above with a very concave and closed angle. And after iridotomy, the natural configuration opens up in part, but not all of the angle, because portions of the angle are permanently closed with synechia. Okay, we want to consider both the angle width as well as whether or not angle structures are visible to judge how much of the angle is closed with peripheral anterior synechia. Now, if we have a patient that has increased angle depth a little bit, but still has peripheral anterior synechia, how can we open the angle further? Cataract surgery alone is known to reduce IOP in all patients, and in patients with angle closure, it can reduce even more. It's been shown to decrease by as much as 7 millimeters of mercury alone. And so cataract surgery can be a way of opening the angle. But if a patient has extensive peripheral anterior synechia, then the pressure may not come down. So mechanical reduction of the synechia with goniosynechial lysis during cataract surgery can be beneficial. Here's a quick video from Ike Ahmed, where you can see in this patient that's had an iridotomy, the angle remains closed. There's peripheral anterior synechia pretty much throughout. With just initial injection of viscoelastic and regonio, you can see here that there are some areas of the angle that have opened up. That's open, but not everywhere. And in his judgment, not enough to lower the IOP. And so using a pair of forceps, there are many different techniques for doing this. He does it with indirect gonio view and a pair of forceps, grasping the peripheral iris and gently tugging, being careful not to disinsert the iris. Mechanically, the angle can be opened, and this can be an effective way of reducing IOP. Studies looking at this have shown, for example, that with phaco alone, about a 30% reduction in IOP can occur, but with goniosynechial lysis, up to 50% reduction in IOP can be seen. Also, with reduction in glaucoma medication use. It's important to recognize that this procedure will create more inflammation, and it should not be considered in patients with uveitic or neovascular glaucoma as the cause for the synechia. They will recur, and their eye will have a lot of inflammation. This should only be considered in patients with primary synechial angle closure or maybe following trauma. Now, it's also important to realize that in many patients, the viscogoniosynechial lysis alone can be effective, and it's not necessary in all patients to do a mechanical goniosynechial lysis with forceps. Now, what about situations where the angle remains closed but not due to peripheral anterior synechia. We do our dynamic gonioscopy, and we see it's only appositional, but the angle still looks closed. We have to think, why didn't the laser iridotomy work? Well, if it didn't work, it may be because pupil block was not the cause of the problem in this patient. And the most common cause of non-pupillary block chronic angle closure is plateau iris syndrome. There are other conditions that cause thickening of the choroid, medications, choroidal effusion, hemorrhage in the choroidal hemorrhage, or can all cause a mass effect. Posterior segment tumors can all push the anterior segment structures forward and lead to a non-pupil block chronic angle closure. But plateau iris syndrome is the most common. Now, it's characterized by an anterior rotated ciliary body that leads to peripheral pushing forward of the peripheral iris that keeps the angle closed due to the mechanical effect of the ciliary body. And when doing dynamic gonioscopy, I don't know if you can see in this video, a furrowing and with a central furrow, but a peripheral hump of the iris that remains forward on dynamic gonioscopy. And you can see in this OCT that in the above case that the ciliary sulcus is very, very thin or absent, and the peripheral iris is pushed forward, in contrast to a broader ciliary sulcus and an open angle in the lower frame. Now, I had a video, but in the interest of time, we'll move ahead. Now, what do we do in such a case? We've done an iridotomy, the angle remains closed. Changing the configuration of the peripheral iris is possible with an argon laser, with a procedure called laser peripheral iridoplasty. Peripheral iris burns cause tissue contraction that then can pull the angle open in the periphery. So here's an example. You can see with each burn, the iris contracts, and this can pull the angle from pull the iris from the angle and change its configuration and open up the angle. And numerous studies have demonstrated its efficacy. One recent study showed an increased angle width, a pressure reduction from 24 to 16 millimeters of mercury, and a reduction in glaucoma medications, and a physically visible on imaging and on gonioscopy enlargement of the anterior chamber angle. The problem is that it's not free from complications. There can be post-laser inflammation and a cosmetic change in the appearance of the iris. In addition, rarely persistent pupillary dilation can occur due to damage, it's believed, to nerves within the iris from this procedure. Finally, its effect seems to diminish over time. And a recent study with 4-year follow-up showed that the majority of patients ended up having increasing intraocular pressure and needing either trabeculectomy or phacoemulsification to help reduce the IOP. Finally, we should consider, aside from plateau iris, the presence of ciliary or body or iris pigment epithelial cysts, also causing this type of forward mechanical movement of the iris. And so imaging of the eye with UBM can be helpful when the cysts are sequestered behind the iris and are not visible at the pupillary margin. And laser iridoplasty has been shown in such cases when necessary to physically open the anterior chamber angle. Now, the final consideration is whether or not phaco alone may be just as effective and may be a more permanent procedure for lowering IOP in comparison to laser peripheral iridoplasty. Cataract surgery or clear lens extraction can provide a more definitive result, and reports of acute angle closure in pseudophakic eyes are exceedingly rare. Although there are some reports that the angle in plateau iris does not open much after phaco, again, you can count on 1 or 2 fingers the number of cases of reported acute angle closure in an eye that's pseudophakic. So it can be a definitive procedure, at least to prevent acute angle closure. Finally, endocyclophotocoagulation can lead to a change in peripheral configuration of the ciliary body. And this procedure, in conjunction with phacoemulsification, has been advocated by some in order to change the iris configuration from behind, again in conjunction with phacoemulsification. You can see here that the contraction burn of the ciliary body alters its form, and the angle can increase in its width anteriorly after endocyclophotocoagulation. So, careful examination of patients is necessary to understand the mechanism of angle closure, to see if there's persistent pupillary block, in which case a completion of the laser iridotomy is needed, how much peripheral anterior synechia is present. When the pressure is controlled and PAS are not progressive, sometimes doing nothing is the right thing to do, controlling the pressure medically. But if the IOP is not controlled or peripheral anterior synechia are progressive, cataract surgery with consideration of visco or mechanical goniosynechialysis is important. And finally, we have to consider non-pupillary block mechanisms for angle closure when the angle remains appositional after laser iridotomy. And there's a persistent risk of acute angle closure, and consider our options of laser peripheral iridoplasty, lens extraction, and or laser cyclophotocoagulation. Thank you very much.